Hello everyone, welcome. We're looking at anatomy of the brachial plexus today. So the brachial plexus, by the end of this video, you should be able to describe the formation of the brachial plexus from the ventral rami C5 to T1. Take note, ventral rami. You should be able to explain the read the dem cadaver book mnemonic. You should be able to identify the 5 terminal branches: musculocutaneous, axillary, radial, median, ulnar, and their major sensory and motor distributions. You should be able to trace the path of the 3 cords relative to the axillary artery. Also, you should be able to differentiate the clinical features of upper versus lower brachial plexus injuries, that is Duchenne versus Klumpke palsy. So, as a way of introduction, the brachial plexus is a network of nerves arising from C5, C6, C7, and T1 ventral rami, ventral or anterior, ventral rami. Location: it exits the neck through the interscalene triangle, that is between the anterior and the middle scalene muscles. Take note, anterior and middle scalene muscles. It exits the neck in between these 2 muscles and passes posterior to the clavicle and enters the axilla. Passes posterior to the clavicle and enters the axilla. This is the scalenus anterior muscle and this is the scalenus medius muscle, and this is the brachial plexus. So it passes in between these 2 muscles. This is the brachial plexus passing in between these 2 muscles. So what function does the brachial plexus serve? It provides nearly all motor and sensory innervation of the upper limb, except for the trapezius muscle and the skin near the axilla. Except for the trapezius and the skin near the axilla. So this is the brachial plexus. As you can see from this image, we have the brachial plexus. These are the roots of the brachial plexus. These are the cords of the brachial plexus. This is the upper limb, showing how the brachial plexus supplies the terminal branches and other branches of the brachial plexus supply the upper limb. We have a table here showing you the roots, the trunk, the divisions, anterior and posterior divisions, the cords, lateral, medial, and posterior, and the major terminal branches of the brachial plexus. So like we said, this is the brachial plexus, this is the subclavian artery. Now, looking at the anatomical organization, the organization is in 5 stages. Remember we said read for R, read, D, trunk, dem for divisions, cadaver for cord, and book for branches. So read the dem cadaver book. That's for the roots. We have C5, C6, C7, C8, T1 roots. For the trunks, now the roots form the trunks. So the C5 and the C6 roots merge together to form the superior trunk of the brachial plexus. The C7 root continues as the middle trunk of the brachial plexus, while the C8 and the T1 roots form the inferior trunk of the brachial plexus. So with that, each of the trunks, the superior, middle, and posterior trunk, divide into anterior and posterior branches. Superior dividing into anterior and posterior, middle dividing into anterior here, and posterior and inferior dividing into anterior and posterior. Now the posterior are colored yellow while the anterior are colored black. Those are the divisions of the brachial plexus. Anterior are colored black, posterior are colored yellow. Now if you look at the posterior, they all meet together. You see, they all meet together. So the posterior division of the inferior trunk, the posterior division of the middle trunk, and the posterior division of the superior trunk meet together to form the posterior cord of the brachial plexus. Posterior divisions meet to form the posterior cord of the brachial plexus. Now we are moving from root to trunk to division. Now we are moving to the cords. While the anterior division of the superior trunk and the anterior division of the middle trunk anterior division of the superior and middle trunk together form the lateral cord, while the anterior division of the inferior trunk continues alone to form the medial trunk. Now remember, we said we have the lateral, posterior, and medial trunk, and these cords are named by their position relative to the axillary artery, which means the lateral cord is lateral to the axillary artery, the medial cord is medial to the axillary artery, and the posterior cord is posterior to the axillary artery. Now let's look at the branches, that is the major branches. For the major branches, the lateral cord gives rise to the musculocutaneous nerve and provides a branch, a contribution to medial nerve. Then the posterior cord gives rise to the axillary nerve and the radial nerve. The radial nerve is the largest branch of the major branch of the brachial plexus. Then the medial cord gives rise to the ulnar nerve as well as contribution to the medial nerve. So the medial nerve is formed by a contribution from the lateral cord and a contribution from the medial cord. Together they form the medial nerve. So we have the musculocutaneous nerve, the axillary nerve, the medial nerve, the radial nerve, and the ulnar nerve. These are the 5 major terminal branches of the brachial plexus. Now the branches, like we said, the terminal branches and the key branches of the root, trunk, and cords. Now if you look at this, there are other branches. There are other branches aside the major branches. There are other branches that arise from the roots. There are other branches that arise from the from the cords, and there are other branches that arise from the trunk of the brachial plexus. But we don't have branches from the division. But we have branches from the roots, we have branches from the cords, and the likes. So let's look at the major branches, both motor and sensory. The terminal branches, both motor and sensory. So branches from the roots. Now we're looking at other branches that can arise from the roots of the brachial plexus. We have C5, C6, C7. These roots, we have the dorsal-scapular nerve. I will be mentioning the nerves as well as the muscles they supply and the clinical relevance of any important one. So the dorsal-scapular nerve is a branch from the roots C5, C6, C7, and it supplies the rhomboids muscles, that is the rhomboides major and the rhomboides minor. It also supplies the levator scapulae, while the long thoracic nerve, the root value C5 to C7, supplies the serratus anterior muscle. So whenever there's a lesion to this long thoracic nerve, which supplies the serratus anterior muscle, we have what we call winged scapula. Winged scapula. There's a video on winged scapula. Make sure you look at it. We'll talk about the scapula itself. Now let's look at the branches from the trunk. We are finished with branches from the roots. We have dorsal-scapular nerve and long thoracic nerve. Dorsal-scapular nerve is root value C5, while long thoracic nerve is root value C5 to C7. Now we have the branches that will arise from the trunk. We are finished with branches arising from the roots. Now let's look at branches that may arise from the trunk of the brachial plexus. We have the suprascapular nerve with root value C5 to C6 from the upper trunk. Specifically, there are branches from the trunk, but this one arises specifically from what? The upper trunk. It supplies the supraspinatus muscle as well as the nerve to subclavius. It supplies the supraspinatus and the infraspinatus muscle. The suprascapular nerve supplies the supraspinatus and the infraspinatus muscle, while we have the nerve to the subclavius that supplies the subclavius muscle located in the inferior aspect of the scapula. This nerve also arises from the trunk. So we have 2 nerves arising from the trunk, and we have 2 nerves arising from the root. Now let's look at the branches. Remember we said we have we have other branches from the roots, from the trunk, from the cord, and the terminal branches. So the branches from the cords. Now look at the terminal branches from the cords. Now from the cords, remember we already mentioned the musculocutaneous nerve for the lateral and the ulnar for the posterior and the auxiliary, and median for the medial cord. So but now we are going to look at the other terminal branches, and remember the mnemonic here is Lucy loves me. Lucy loves me. That is from the lateral cord. Other branches we have, what are they? We have the lateral pectoral nerve, the lateral root of median nerve. Remember we said the lateral cord gives a contribution to form the median nerve. So we have the lateral root of median nerve, and we have the musculocutaneous nerve. Lateral pectoral nerve, lateral root of median nerve, musculocutaneous nerve. Make sure to revise this, write it down, revise this over and over so that you'll be able to remember. Now, branches that are coming from the medial cord, we have the mnemonic. Most medical men uses morphine. Most medical men uses morphine. We have the musculocutaneous nerve of the arm. We have the medial cutaneous nerve of the forearm. We have the medial pectoral nerve. We have the ulnar nerve, and we have the medial root of the median nerve. Take note, medial root of median nerve. So for the medial cord, we have medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial pectoral nerve, ulnar nerve, and median root of median nerve. For the posterior cord, we have the mnemonic ulnar. Just use the mnemonic ulnar. We have the upper subscapular nerve, we have the lower subscapular nerve, we have the nerve to latissimus dorsi, we have the axillary nerve, and we have the radial nerve. So this is an image of this everything all together. We have the roots, we have the long thoracic nerve, we have the trunk, we have the nerve to subclavius, and for the root we still have the dorsoscapular nerve. Then for the trunk we have the suprascapular nerve and the nerve to subclavius. For the divisions, we don't have any branches from here. For the cords, we have several branches. For lateral cord, we have lateral pectoral nerve, we have the lateral contribution to median nerve, we have the musculocutaneous nerve. For the posterior cord, we have the axillary nerve, we have the radial nerve, the medial cutaneous nerve of arm, we have the thoracodorsal nerve, we have the lower subscapular nerve, we have the upper subscapular nerve. While for the medial cord, we have the medial cutaneous nerve of arm, medial cutaneous nerve of forearm, the ulnar nerve, and contribution of the lateral cord and medial cord that together form the median nerve. So a quick mnemonic for recall, we have the roots to branches. Read the Dem cadaver book. That's for roots, for trunks, for divisions, for cords, and branches. For the terminal branches, from lateral to medial. Take note, from lateral to medial. Mama eats rice, making us smile. Mama eats rice, making us smile. That's musculocutaneous, axillary, radial, median, and ulnar. Those are the major branches, terminal branches we have. Now, cords around the axillary artery. Remember, we see the cords are named in relation to the axillary artery. The lateral cord is lateral to the axillary artery, the medial cord is medial to the axillary artery, and the posterior cord is posterior to the axillary artery. Then let's look at clinical correlates. What are the clinical significance of this knowledge? We have Duchenne palsy, also called the upper plexus injury. And the mechanism of this injury, there's an excessive widening of the neck angle, the neck to shoulder angle. Look at the angle between your neck and your shoulder. When you increase that angle, this is common in birth trauma and falling on the shoulder, also called waster's tip. When one falls in that situation or in that position, there's an increase in the angle between the neck and the shoulder, and the nerves injured are C5 and C6. Remember, the C5 root and the C6 root together form the upper trunk. So we call this the upper trunk. So you can be referred to as upper plexus injury. The muscles paralyzed are supraspinatus, infraspinatus, deltoid, biceps, and brachialis. The deformity is called waiter's tip, where the arm hangs adducted. Take note, the arm, not the forearm. The arm is adducted and internally rotated. The arm is adducted and internally rotated. The elbow is extended, and the forearm is what? Pronated, in that sequence. Arm adducted and internally rotated, elbow extended, forearm pronated. Sensory loss, there's loss of sensation in the lateral aspect of the arm and forearm. So this is an image of upper plexus injury, where there's damage to C5 and C6 nerve roots. You see there's a forward rotated arm, the upper arm redness, muscle atrophy and diminished arm length, Waiter's tip deformity. Don't forget this, Waiter's tip deformity, don't forget that. And we have drooping of the upper eyelid and smaller pupils, which can be due to Horner syndrome because of affectation of the sympathetic fibers of the eyes. We also have the Horner syndrome. We have also bird winging scapula. Now, Klumpke's palsy, this is where you actually have the Horner syndrome. In Klumpke's palsy, the mechanism is that the arm is hyper abducted, unlike in Erb's palsy, where the problem is an increase in the angle between the neck and the shoulder. In this situation, we have a hyper abducted arm when one is grasping a tree branch during a fall or birth injury with the arm overhead. Nerves affected, we have C8 and T1, which together form the lower trunk, remember. So we can also call this the lower plexus injury. Muscles paralyzed, we have the intrinsic muscles of the hand because of affectation of the ulnar and median nerves. We have deformity called the claw hand. In Erbs, we called it Waiter's tip. Here we are calling it the claw hand. There's the metacarpophalangeal joints are hyperextended, the interphalangeal joints are flexed, and the ring and little finger are flexed as well. Then we have sensory loss on the medial and forearm, medial aspect of the arm and the forearm. In Erbs, we have the lateral aspect of the arm and forearm. Associated signs, we have Horner syndrome, where you have ptosis, meiosis, anhydrosis, and if the T1 root is avulsed, there's damage to sympathetic chain, which causes Horner's syndrome. We'll have a video on Horner syndrome. Expect that soon. Then this is what we have. This is how the hand will appear, and can occur due to this injury: hyperextension of the arm, and during a breech delivery. During a breech delivery, we can have the Klumpke's palsy or lower plexus injury, excessive upward pull of the hand or traction. So comparing both injuries, we have Klumpke's palsy on this side and Erb's palsy on this side. Take note to look at it. Here we call it the Waiter's tip posture, and here we call it the claw hand deformity. That will be all for this video. Thank you for watching. Don't forget to like, share, subscribe to Alacrity Explains Anatomy for more videos subsequently. Thank you.